students, back with another session here. Here in this lecture, we'll discuss about mitral stenosis and peripartum cardiomyopathy. As you already know, mitral stenosis is a very important disease during pregnancy. It is the most common valvular heart disease during pregnancy. So, mitral stenosis is the commonest heart lesion met during pregnancy. The normal vital valve size is 4 to 6 centimeters square, but if its size is less than 2.5 centimeters square, okay, it is a stenotic condition, stenosis. Okay, it is a mitral stenosis, and if it is lesser than 1 centimeter, lesser or equal to 1 centimeter per square, then the person will have a higher rate of pulmonary edema 55% and arrhythmias 33%. In an asymptomatic cases, generally the mortality rate is less than 1%, but if the person will appears with the symptoms or will be significantly symptomatic, the mortality range increases and increases up to 5 to 15%. Okay, and during labor, continuous epidural analgesia is preferred. It is ideal, and intravenous fluid overload is generally avoided to prevent heart failure. Okay, to prevent heart failure, to save the patient, from heart failure. It's to be done to be avoid the fluid overload. And the place of valvotomy, it is better to withhold elective cardiac surgery during pregnancy. So should not perform any cardiac surgery during pregnancy. It is not good for a patient, but if it is necessary and in cases of unresponsive failure with pregnancy beyond 12 weeks, we can think about surgery, and the surgery of choice at that time will be balloon valvuloplasty, and the best time to do is second trimester of pregnancy. 14 to 18 weeks is the second trimester of pregnancy, and the surgery of choice is balloon valvuloplasty, and surgery which is contraindicated here will be valve replacement. It is valve replacement. And the next thing about peripartum cardiomyopathy. Peripartum, that means near to the delivery, around delivery. Okay, so development of cardiac failure in the last month of pregnancy or the 5 months after delivery. So last month of pregnancy or either the 5 months after delivery. Second criteria is left ventricular systolic dysfunction. It is systolic dysfunction. Then absence of any identifiable cause for cardiac failure, and on the echocardiography you will get dilated left ventricle and decrease ejection fraction. Okay, this is the Pearson diagnostic criteria, which is a very important criteria in terms of exams also, or in a general terms also. It includes four things: left ventricular systolic dysfunction, development of cardiac failure in the last month of pregnancy or 5 months after delivery, any identifiable cause, no identifiable cause is there before, and on echocardiography dilated left ventricle and decreased ejection fraction. Then it occurs due to prolactin hormone. So bromocriptine can be given as treatment, as bromocriptine is effective because it inhibits the prolactin secretion. Okay, it inhibits the prolactin secretion. So the next is treatment. Treatment includes to decrease preload reduction, in reducing afterload. So reducing preload and afterload. Bed rest is important. So bed rest, digoxin, diuretics for preload reduction, hydralazine or ACE inhibitors can be given for afterload reduction. Beta blockers can be given. Anticoagulant therapy can be preferred. Now the vaginal delivery is a preferred method for delivery in the peripartum cardiomyopathy. The mortality risk is obviously higher due to congestive failure and arrhythmias, thromboembolism, but vaginal delivery is preferred. Epidural anesthesia is generally used, and there is no contraindication to breastfeeding, and this condition may occur in the subsequent pregnancies also. This is all about peripartum cardiomyopathy. Thank you so much for watching my video, and do not forget to press the bell icon. You will be notified for the next videos. Okay, thank you.